Uh, in the name of Allah, uh, I am Muhammad Hashim Kamran, student of Master uh, in Medical Faculty of Al Farabi, Kazakh National University, and I would like to deliver my today's lecture about the pharmacology of general anesthesia for the bachelor students of the same faculty of Al Farabi, Kazakh National University. And I hope that after delivering of this lecture, you students know about the pharmacologic agents of uh, anesthesia, general anesthetics, and local anesthetics. And after delivering this lecture, you will know about all these issues. And during the lecture, we will talk about the definition of anesthesia and definition of anesthetics drugs or anesthetic agents, and we'll talk about the cardinal features of general anesthesia, and then we'll talk about the stage of general anesthesia and how many stages general anesthesia does have, and you will know at the end of this lecture. And we'll talk about the difference between general and local anesthetics and mechanism of general anesthetics and how general anesthetics um, act and how they affect the patients during the operation and procedure. And then we'll talk about the classification of general anesthetics, and then we'll talk about the inhalational anesthetics. We'll talk about the different inhaler anesthetics and different intravenous anesthetics. These are the table of content of our today's lecture. So what is anesthesia? Uh, Anesthesia is a reversible condition of comfort for the patient within the physiologic limit before, during, and after performance of a procedure. So, in the definition of anesthesia, we have two main parts. The first one is reversibility of anesthesia. It is the first characteristic of anesthesia. Every anesthesia should be reversible. So if it is not reversible, it cannot be anesthesia. If the second one is physiological limit, every anesthesia, even it is general anesthesia, it is local anesthesia, it is spinal anesthesia, it is inhaler anesthetics, it is intravenous anesthetics. So it should be within the physiologic limits. It is, if it is not within the physiologic limit, it is out of the physiologic limit, then it will be a pathologic limit. It will have a pathologic limit, then it will not be an anesthesia. So it is a reversible and physiologic limit condition that patient feel comfortable during the procedure, before the procedure, and after the procedure. If the patient is not comfortable before the procedure, but comfortable during the procedure and after the procedure, of course, it is again cannot be a very ideal anesthesia. It can be anesthesia, but not ideal anesthesia. Ideal anesthesia is this, that the patient should be comfortable before the procedure, during the procedure, and after the procedure. Procedure mean operation, okay? In general anesthesia, for surgical procedure to render the patient unaware, unresponsive to the painful stimuli. Of course, in general anesthesia, we have some issues which is different from local anesthesia, and we'll talk about it later. Drugs producing general anesthesia are called general anesthetics. So when we say general anesthetics, it means that and drugs which are used for general anesthesia or agents which are used for general anesthesia. And what is local anesthesia? Reversible inhibition of impulse generation and propagation in nerves, in sensory nerves. Such an effect is desired when painful procedure must be performed. Example, surgical or dental operations. Local anesthesia, the main part of local anesthesia is this: it is just applied in one area, in one region. It does not take whole body. The most important difference between general anesthesia and local anesthesia is this: that in general anesthesia, whole body is involved, but in local anesthesia, only one part of the body, only one region of the body is involved. So, which drugs are used for local anesthesia? Of course, we'll talk about this in our next lecture about local anesthesia. This lecture is only about general anesthesia, and the drugs, just I would like to take the name of these drugs: procaine, lidocaine, and bupicaine are the most famous and the most common drugs which are used in general anesthesia. So what is general anesthesia? The state of general anesthesia usually includes general anesthesia includes many things: analgesia, amnesia, loss of consciousness, and autonomic reflexes and skeletal muscle relaxation. So, in general anesthesia, the patient should not feel the pain. The patient should not feel the pain. It means that the patient should have a good analgesia. The patient should not know uh, the environment. It means that should have amnesia, and the patient should not know her or his orientation. The patient should have loss of consciousness, and the patient should have skeletal muscle relaxation. If there is no muscle relaxation, you never be able to do an operation on the patient. This is why, beside losing pain, beside amnesia, beside uh, condition of unconsciousness, the patient should have muscle relaxation. If there is no muscle relaxation, uh, the patient will not be operated. We will not be able to operate the patient. So that is why, for reaching to these aims, to these goals, there is no just one drug. We should have many drugs to do this kind of activities. No single anesthetic is capable of achieving all of these desirable effects without some disadvantage when used alone. Thus, the modern practice of anesthesia involves the use of the combination of drugs. Combination of drugs like using intravenous or inhaler general anesthetic, like using benzodiazepine, like using opiates and analgesic, like using muscle relaxant. When you use all these drugs, then we will achieve the desirable effects of drugs which are needed for an operation. So one other term is balanced anesthesia, includes the administration of medication preoperatively for sedation and analgesia, the use of neuromuscular blocking drugs, or shortly we can talk about balancing anesthesia. Balanced anesthesia is the anesthesia that at the same time uh, we use what? We use inhaler anesthetic and intravenous anesthetic. When we use both of them at the same time, at the same patient, so it is called balanced anesthesia. So it is the characteristic of general anesthesia. These four characteristics are the most important characteristics of general anesthesia. First one is loss of all sensation, especially pain. The patient lost her or his all sensation. Especially, patient should not feel the pain during anesthesia and during procedure. So the second most important characteristic is sleep and amnesia, abolition of asomatic and autonomic reflexes, and immobility and muscle relaxation. Of course, when there is muscle relaxation, the patient cannot uh, be mobile, the patient cannot move. So states of general anesthesia, we'll talk about this, but before we talk about states of general anesthesia, I would like to talk shortly about that. It is not very important because it is a classic classification. It is a classic staging of general anesthesia because before in anesthesia, diethyl ether was used very common. It was very common and used very common. That is why the diethyl ether was a higher blood. It had a higher blood solubility. When it has a high blood solubility, then the concentration of this drug will be low in CNS. So the induction of the time of induction for this drug is very long. That is why when the procedure of anesthesia or the action of anesthesia uh, or the duration of anesthesia becomes long, so you can see these states. So when you use ethyl ether, you can see these states. But if you use other agents, other anesthetic drugs, you will not be able to see these states. The most important four states of general anesthesia are stage one. Stage one is analgesia. It is the analgesia state. This stage starts from beginning of anesthetic administration and lasts up to loss of consciousness. The patient feels like a dream state, and the patient is mostly reflex, but respiration remains normal. In this stage or stage one, when you give ethyl ether for the patient, in stage one, the patient does not feel pain, the patient relax, the patient feels like a dream state, but the patient can can expire. The respiration is normal, is not irregular, and but there is no amnesia. But later, at the beginning of second stage, amnesia will be begin. So in second stage, it is a stage of delirium. So from loss of consciousness to beginning of irregular respiration. In this stage, muscle tone is increased, especially in jaws. Muscle tone is increased and excitement is seen. And very, very excitable movement will have the patient. And jaws are tightly closed. Heart rate is increased, blood pressure is increased. And in this stage, respiration is irregular and vomiting will be occurred in this stage that the anesthesiologist and the medical staff who are in operating room should know about this issue. And third stage, it is the surgical anesthesia. It is a stage that we can do our operation, our procedure, extends from onset of irregular respiration to cessation of spontaneous breathing. This has been divided in four plans. So in this stage, uh, the respiration will be irregular, and the end of this stage, respiration will be stopped totally. So it is very important. It is very important in this stage. The patient should have supportive measurements, supportive tools for artificial respiration, like intubation, endotracheal tube applying. And the plan of this stage are plan 1, plan 2, plan 3, and plan 4. In plan 1, this plan ends when eyes become fixed. Plan 2, loss of corneal and laryngeal reflexes. When these reflexes is lost, then it will be the plan 2, stage 3 of our anesthesia. People start dilating and light reflexes. In plan 4, dilated people decrease muscle tone and blood pressure will fall. In stage 4, it is medullary paralysis. It begins with cessation of spontaneous respiration. There is severe depression of the respiratory center in the medulla and vasomotor center as well, without full circulatory and respiratory support. Coma and death ensures. So it is very dangerous, my dear students, that in this stage of anesthesia, we should support the circulation of the patient, the respiration of the patient. If we don't support, it means that the patient goes to coma and even death will ensue, and the patient will face death because the respiration center in medulla uh, will be cease the activity. So general anesthetics are the drugs which produce reversible loss of all modalities of sensation and consciousness, or simply a drug that brings about a reversible loss of consciousness. These drugs are generally administered by an anesthesiologist in order to induce or maintain general anesthesia to facilitate surgery. So, guys, even you as a professor of surgery cannot be able to use these drugs. These drugs are only and just used by anesthesiologists. No other person, no other doctor, and no other uh, health staff can use these drugs on the patient because it is very dangerous. As we talked about states, if we administer these drugs for the patient and do not have any supportive instruments and issues, at the time our patient will goes to coma and even death. In general anesthetics are mainly divided as a classification of general anesthetics. There will be two kinds of general anesthetics. The first one is inhalation anesthetics, and the second one is intravenous anesthetics. So balanced anesthesia, as we talked before about this, it is a combination of IV anesthetics and inhaled anesthetics. When you use uh, when you use intravenous anesthetics and inhaler anesthetics at the same time, then uh, it is called balanced anesthesia. So uh, now mechanism of action uh, of general anesthetics increase the threshold of cells to firing, resulting in decreased activity, reduce the rate of rise of action potential by interfering with sodium influx. The most important mechanism of action of these drugs are like this. When we stimulate a cell, for example, the skin of our body is stimulated with something. So at the rest condition or the rest state of the cells, there is no any influx or outflux of sodium from outside to the inside of cell or from inside to the outside of cell during the rest state. But when we stimulate our cells, then sodium influx will be occurred, and sodium will goes inside to the cells, and it will create action potential, and it will activate the cells, and then the cells will be activated, and it will especially neurons, it will transmit the stimulus to the CNS, central nervous system. if we if we administer these anesthetics, these anesthetics inhibit uh, influx of sodium inside the cell. When sodium does not goes inside to the cell by stimulation, and that time the neurons will not be able to transmit the stimulus, especially pain stimulus, and that time the patient will not feel any kind of pain during the uh, procedure. and essential components of general anesthesia. About the cardinal features of anesthesia we talked before, it was four features: loss of all modalities of sensation, sleep and amnesia, immobility or muscle relaxation, and abolition of reflexes, somatic and autonomic. And the triad of general anesthesia should be these three: unconsciousness, analgesia, and muscle relaxation. These are the triads of general anesthesia. If one of these things is not present in anesthesia, it is not general anesthesia. It cannot be general anesthesia. This should be tried, and all of this should be reversible. It should not be irreversible, and it should be within the physiologic limit. Anesthesia, or something that we see practically inside the operating room. These three things will be occur in operating room. The first one is induction, the second one is maintenance, and the third one is recovery. In induction, it is the period of time which starts with an administration of anesthetic up to development of surgical anesthesia. In surgical anesthesia, we talked before, in surgical state of anesthesia or surgical stage of anesthesia, we talked before that in this stage, respiration is irregular and even respiration is ceased, and it stops. So the patient needs respiration support and artificial respiration. And by inducing agent, it will be occurred. Thiopentan sodium will be an induction agent, but we can use propofol as well. And nowadays, propofol is very useful, and most anesthetics or most anesthesiologists use propofol. Second, maintenance of anesthesia, sustaining the state of anesthesia, done by inhalation agents. It is called nitrous oxide or halogenated hydrocarbons. But it is not necessary that for maintenance of anesthesia we use inhaler anesthetics. We can use intravenous anesthetics as well. For example, propofol is used for both induction of anesthesia and maintenance of anesthesia. Or you can induct anesthesia with thiopentan sodium. It is intravenous agent, and maintain your anesthesia with nitrous oxide is inhaler. So you can create a combination of intravenous and inhaler anesthesia, which is called balanced anesthesia. In the stage of recovery, in recovery stage, anesthetics is stopped at the end of surgical procedure and consciousness regains. So you don't administer any maintenance dose of your drugs. So when you stop it, gradually the patient will wake up because it is anesthesia, because it is reversible. That is why it is a good thing. And at the end of procedure, you do this. At the end of procedure, you stop it. So classification of our anesthetic agents, it is the pharmacology of anesthetic agent, anesthetic drug. So it is classified in two groups: inhalation anesthesia or anesthetics and intravenous anesthetics. In the left side, you see inhalation anesthetics. In the right side, you see intravenous anesthetics. It is classified in two kinds: gas and liquids. Nitrous oxide is the only gas which is used as inhaler anesthetics, and liquids which is vaporized during administration are ether, haloton, enfluoran, azofluoran, sevofluoran, disfluoran, and azofluoran. And nowadays, in modern anesthesia, azofluoran is the most useful one, the most common one, which is used uh, commonly by anesthesiologists. But in the right side, you see the list of drugs which are used as intravenous agents for general anesthesia. Inducing agents are tiopentan and metoxetan, sodium, propofol, and etomidate. As I told before, that propofol is the most useful one. Propofol is the most common one which is used in modern anesthesia. And benzodiazepines, diazepam, lorazepam, midazolam. Among these three, diazepam, lorazepam, midazolam is the best choice, which is used nowadays. And dissociative anesthesia, ketamine is used, and we talk about ketamine, about propofol, and about tiopentan later. And neuroleptic analgesia, fentanyl. Fentanyl is opiate analgesic. So we can use pentazocine instead of fentanyl, but if you have fentanyl, it is a good choice, but we can use pentazocine as well, because we talked before about general anesthesia. There should be a combination of drugs. By one drug, we cannot achieve all characteristics of all triads of general anesthesia. For example, for pain, we, we administer fentanyl or pentazocine. For amnesia or sleep, we uh, administer diazepam, midazolam, or lorazepam. And for loss of consciousness, we administer intravenous anesthetics like propofol and like tiopentan and like ketamine, like these things. So inhalation agents, nitrous oxide is an important component of many anesthesia regimes, but nowadays it is not used very commonly. And cyclopropane, it has limited use nowadays because it is inflammable. It is inflammable. That's why it has a great risk, especially inside the operating room. And the second one is volatile liquids. Halotan, enfluoran, isofluoran, and methoxyfluoran are used commonly. Ether, isofluoran. I like this one. Isofluoran is used commonly. Ether has limited use. In here, cyclopropane has limited use. In here, ether is used limited. It has limited use. And we talked before that it is a classic anesthetic and four states of anesthesia as well seen by ether. And chloroform has limited use because of organ toxicity, and ether because of potentially inflammable as well. So this is as well, this slide is as well talking about the classification of general anesthesia, and we talked in last slides. And pharmacokinetics of inhaled anesthesia. So the rate at which a given concentration of anesthetics in the brain is reached depends on. So for this, that we have a good, an ideal, and a standard, and a desired general anesthesia, the concentration of our agents should be reached in a standard level inside the central nervous system. Okay, so when we achieve this goal to raise the concentration of our anesthetic agents in the inside the central nervous system, it depends on these things: the solubility of anesthetics in the blood, the concentration of anesthetics in inspired air when we push the back, or when oxygen goes inside the lungs and alveoli. So the concentration of our anesthetic is how much inside this inspired air. Pulmonary ventilation rate, pulmonary blood flow, and the concentration gradient of anesthetic between arterial and mixed venous blood. So we talk about all of them. Solubility. Now, nitrous oxide with low solubility in blood reaches high arterial tension rapidly which in turn results in more rapid equilibrium with the brain and faster induction of anesthesia. In contrast, even after 40 minutes, methoxyfluorine has reached only 20% of the equilibrium concentration. So, in this slide, we discuss about nitric oxide. Compare nitric oxide with methoxyfluorine. Nitric oxide, it has low solubility in the blood. If it has high solubility in the blood, so it does not go to neurons. It does not go to CNS. So the concentration of this agent inside the CNS will not reach to the desirable level that you want in a short time. So it means that when the solubility of the agent is high in the blood, then the induction phase will be longer. Okay? If the solubility is low, the induction will be faster because it does not have solubility with the blood. It fly from the blood, goes to CNS. When it goes to lots of agent, high amount of agent goes to CNS, then it will reach very fast at the desired level. So high solubility, long induction. Low solubility, fast induction. Nitrous oxide, low solubility. Nitrous oxide, low solubility, then it is fast. Methoxyfluorine, high solubility, then it is long. Concentration in inspired air. If the concentration of our agent is high in inspired air, of course, the induction will be fast. But if it is low, the induction will be long. Okay? Because when it is high, then you will have a lot of agent. Then you will have more amount of drag which goes to central nervous system. And pulmonary ventilation. When pulmonary ventilation is high or increased, then again the induction will be fast. When there is increase in pulmonary ventilation, okay, and anesthetics with low solubility but can significantly increase tension of agent with moderate to high blood solubility. Then pulmonary ventilation is very important. When pulmonary ventilation is increased, then a large amount of our agent will go to circulation and then goes to nervous system. Pulmonary blood flow, an increase in pulmonary blood flow slows the rate of rise in arterial tension, particularly for those anesthesia with moderate to high blood solubility. It means that when pulmonary blood flow is high, then lots of blood comes to alveolus, and then lots of agents will be absorbed to the blood, and then there will be a high level of drag inside the blood. When blood has a high level of our drug and agent, then high level of agent will goes to CNS, and then we have a rapid induction and rapid effect of our agent. So venous blood returning to the lungs may contain significantly less anesthetic than that present in arterial blood. Of course, when we compare arterial blood with venous blood, arterial blood takes lots of agents from the lungs and goes to the nervous system, and venous blood will comes back to the lung. It has very low level of agents. So we can compare arterial blood and venous blood like this. If the greatest difference, it is a difference, there is a difference. this difference, if the greater this difference in tensions, the more time it takes to achieve equilibrium. If this difference is high, then it means that the induction will be long. We need more time, okay, to achieve equilibrium. If this difference is low, it means that the induction will be fast. Okay, clinical pharmacology of inhaled anesthetics effects on cardiovascular system. Now we are talking about the effects of these agents on different systems and different organs, because it is very important in which condition, in which comorbid condition we should, for example, select which drug. For example, a patient has pregnancy, a patient has, for example, high blood pressure, a patient has ischemic heart failure, a patient has, for example, high intracranial pressure. So in these cases, in these special cases, which drug is selective? Which drug should be used? Which agent should be used? Now we should know the effect of these drugs on many systems. For example, and blood pressure. Halotan and enfluran decrease the blood pressure due to a reduction in cardiac output. Isoflurane due to a decrease in systemic vascular resistance, not cardiac output. Okay, so halotan, enfluran, and isoflurane, three of them decrease the blood pressure. It causes reduction of blood pressure. So when your patient is hypertensive, you can use halotan, you can use isoflurane, you can use enfluran, all of them, because they will not increase the blood pressure. Vice versa, it decreases the blood pressure, and during the procedure, blood pressure of your patient will not raise. But diethyl ether and cyclopropane raise the blood pressure by their ability to liberate catecholamines. Diethyl ether and cyclopropane, they cause secretion of catecholamines, and catecholamines will cause high blood pressure in your patient. Of course, halotan cause bradycardia by direct depression of the atrial lid. Methoxyfluorine, enfluran, and isoflurane increased heart rate. They increased heart rate because enfluran, isoflurane, and methoxyfluorine, we talked before that they decrease blood pressure. When there's hypotension, heart rate goes up and it is increased. Enfluran and halotan are very depressant. Nitrous oxide is also depressant. Cyclopropane, ethyl ether, and fluoxetine are not. So they are depressants, cardiac depressant. So when they are cardiac depressant, so when they press the heart, it causes bradycardia. So when a patient has tachycardia, then you should not use methoxyfluorine, enfluran, and isoflurane because they increase more and more the heart rate. If your patient is bradycardia, then it is a very good choice, these drugs. Yeah, and they are depressant. Nitrous oxide is cardiac depressant. It means that it decreases the heart rate. So if your patient is bradycardia and you administer nitrous oxide, it means that the patient will go to becomes more bradycardia. So it's good for bradycardic patient. You should not use nitrous oxide. But for tachycardia patients, For the patient with tachycardia, you should not use these drugs. Okay, it's very useful. In the respiratory system, with the exception of nitrous oxide and diethyl ether, which liberate catecholamines, all inhaled anesthetics are respiratory depressants and they cause an increase in resting pressure, carbon dioxide with isoflurane and enflurane being most depressant. So, inhaled anesthetics depresses mucociliary function with the resulting pooling of mucus, atelectasis, no air at alveoli, and respiratory infections. Inhaled agents are bronchodilators, halotan being most potent. So, all of them, all of them are depressant for the lungs, for the respiration. Okay, and they are mucociliary and they cause atelectasis and they cause the collection of mucus inside the alveolus, inside the bronchus, inside the bronchiole. So when it has these effects, when your patient has some kind of lungs infection, pneumonia, and cough with sputum or COPD, so inhaler anesthetics will not be a good choice for them. If you want to administer inhaler anesthetic for them, then nitrous oxide and diethyl ether would be the best one among these agents. And brain, inhaled anesthetics decrease metabolism in the brain. They increase cerebral blood flow by decreasing cerebral vascular resistance. Hyperventilation of the patient before the anesthetic is given avoid increase in the intracranial pressure from inhaled anesthetic. So there is a solution for this. Before I talked about the high pressure of intracranial pressure. When intracranial pressure, for example, for the patient or with the patient who has head trauma or has hydrocephalus. Intracranial pressure is high. So in this time, if you use these drugs, inhaler agents, it will cause decreasing of vascular resistance. When vascular resistance decreases, the blood flow will increase. When blood flow is increased inside the brain, then the inside intracranial pressure will increase more and more. So in this time, it will cause danger for the patient. For For preventing that, hyperventilation is a good choice before anesthesia that we can apply it. On the kidney, because all inhaled anesthetics decrease the blood flow to the kidney. When it decreases the blood flow to the kidney, then it decreases GFR. GFR is decreased, and as well, uh, blood flow is decreased. So for the patient who has renal artery stenosis, ischemic condition of the kidney, or a very low function kidneys, so in this time these agents will not be a good choice. On the liver is not very important. It is a transient change in function test, and decrease in hepatic blood flow. When hepatic blood flow is decreased, and the time all metabolite which is cleaned by the liver, the cleaning function of the liver will be decreased in this situation. But it is not important because the procedure will continue for 1 hour, for 2 hours. But if it is a long procedure for 4 hours, 6, 8 hours, even 10 hours, then it should be selected carefully, these agents. Effects on uterine smooth muscles. Isoflurane, halotan, and enflurane are potent uterine muscle relaxant, useful in intrauterine fetal manipulation, but will cause increased bleeding during dilatation and cortage. Of course, when it causes muscle relaxation of the uterus, then when a patient with pregnancy comes for a procedure, okay, for example, acute appendicitis needs emergent operation. It is an emergency case. Cannot postpone it up to end of procedure, up to end of pregnancy, up to delivery. That's why we have to do operation. For this patient, if we administer these drugs, it will cause muscle relaxation of the uterus, and it will cause miscarriage, and for cesarean section, after delivering, the uterus will not contract and bleeding will occur, postpartum bleeding. Toxicity, hepatotoxicity is common with halotan and chloroform, and nephrotoxicity is common with methoxyfluoran. Carcinogens, effects of these drugs are not clear till now, and production, just miscarriage will be occurred when the patient is pregnant. I talked about acute appendicitis in pregnant woman. We should be careful, and in this case, we can consult gynecologist. Intravenous anesthetics, tiopentan and metoxital, propofol, opiate analgesic, neuroleptics, ketamines, and we talked about this. And it is tiopentan. Tiopentan is 12 to 16% per hour. It is metabolized. Tiopentan will cause fall in blood pressure. It will cause stroke. Volume and cardiac output will decrease by tiopentan, and it is as well a potent respiratory depressant. And it is like inhaler anesthetics, decrease the blood flow and GFR. So propofol, it is the most useful drug nowadays. It is replacing tiopentan now, and continuous infusion. It is used both for induction and for maintenance of anesthesia, because it has a rapid induction effect, and after 15 and 45 seconds, the patient will sleep, and for 5 and 10 minutes it will continue, and then for maintenance you will administer 9 milligram per kg per hour IV. For induction, you will administer 2 milligram per kg per IV bolus, and it has rapid distribution. As I talked, 15 to 45 seconds, and rapid distribution as well. Extensively metabolized. 88% of an administered dose appears in the urine, metabolized by hepatic conjugation of the inactive glucuronide metabolized. So, advantages of propofol are rapid induction, does not synthesize myocardium to adrenaline, no nausea and vomiting, no explosive and no irritant to airways. It is total IV anesthesia, not balanced, not inhaler, short operation alone in OPDs. In OPD, you can use it, not in operation. Disadvantage, induction apnea. During induction and apnea, about 1 minute will occur, so the anesthesiologist should know about this event, because it will cause apnea and it will cause hypoxia, brain hypoxia. Hypotension will occur, vasodilatation, so the anesthesiologist should know the bradycardia frequently, dose-dependent respiratory depression, pain during injection, local anesthetics, and combination with other drugs will not be preferable. Ketamine is a powerful analgesic. It is not analgesic, but it has a very powerful characteristic of analgesia, and produce cardiovascular stimulation via central sympathetic. So when it stimulates the cardiovascular system, especially the heart, then it is sympathomimetic. It increases the heart rate, it increases the blood pressure. So it is not a good drug for hypertensive and tachycardia patients. And increase cerebral blood flow as well, so increase the intracranial pressure as well, so it is not good drug for those patients who has a high intracranial pressure, and it causes disorientation. It is not a good effect of this drug. After sensory and perceptual illusion and vivid dreams follow anesthesia is a problem. This can be avoided by giving diazepam. When you give diazepam, 0.2 to 0.3 milligram per kg, then these effects of this drug will be decreased by administration of diazepam. And etomidate cause rapid induction of anesthesia with minimal cardiovascular system and respiratory change. It is lipid soluble with VD of 4.5 liter per kg, excreted mainly as metabolites in the urine, produce hypnosis within 2 seconds, hypotension and low frequency of apnea, cause high incidence of myoclonian pain during injection. It may cause adrenocortical suppression via inhibitory effects on steroidogenesis. Benzodiazepine, diazepam, lorazepam, midazolam. Midazolam is the most important one, should be used, and propanidine produce anesthesia as rapid as tiopentan. Recovery is more complete. Guys, these drugs are not very important, okay? The most important one is propofol, that always we should use that. It is very good. It is very ideal drug, and it is very good drug. All other uh, side effects that we see with propanidine, with ketamine, with tiopentan, uh, we do not see it with propofol. So propofol is the best intravenous agent, and isoflurane is the best uh, inhaler agent. Okay, guys, it was our today's lecture and about general anesthetic agents. Hope that you have some idea about pharmacology of anesthetic agents. And in our next lecture, we will talk about local anesthetics. And everybody should be present, and it will be a good and interesting lecture. Have a nice day. Goodbye.